This is the November meeting. Good morning. This is the November meeting of the Joint Public Health Board between representatives of Dorset Council and Bournemouth, Christchurch and Poole Council. The first item on the agenda today is the election of chairman. The chairman will be elected of Bournemouth, Christchurch and Poole Council. So can I have a nomination for chairman, please, for the meeting?
I'd like to propose Councillor Nicola Green.
Thank you. And as there are, in practical terms, no other nominations, Councillor Green, you're chairman for the meeting.
Thank you very much, David, and good morning, everybody. We'll move on to item 2, which is the appointment of a vice chairman. I wonder if we could have a nomination in line with the normal protocol. Councillor Rampton.
I'd like to propose Councillor Laura Miller.
In which case, there being no other nominations, Councillor Miller, thank you very much for taking on this role. David, I wonder if you'd kindly take us through items 3 and 4 before we move on to the minutes.
Yes, items 3 and 4 are the declarations of interest that anyone wishes to make. Okay. And secondly, it is, we've got the minutes, but I've put on the terms of reference as well. So, okay, I think we can probably take the next couple of items as read, as my understanding. And there's no public participation today, I've received.
Thank you, David. And does that cover us off as well for item 7?
Indeed, it does.
Right, thank you. The forward plan is also very well set up. I think everything which we were due to be looking to today is covered elsewhere on the agenda. So are we happy, therefore, to note the board's current forward plan?
Chair, if I may, just a couple of quick points on the forward plan. Looking forward to February, we've got 2 items there. One is the standing item on the finance paper. I'd just like to make the board aware that we'd be intending to take a financial annex to the partnership agreement. So that would be the meeting where we'll agree the contributions to the partnership, and I'll explain more about that as we go through the meeting because it relates to the renewal of the partnership agreement. The only other item I wanted to flag under the forward plan was that we normally have a report on the monitoring of the business plan. I'll be perfectly honest, our business plan is in pieces this year, so we will need to think through what would be an appropriate substitute paper which reflects what we've actually been doing around the COVID response. So I just wanted to make the board aware of that. So I'll give that some thought so that we've got something that actually reflects what we've been doing so you can scrutinise the performance of the team in February.
Thank you, Sam. I think that would be very welcome. It occurs to me I've been rather remiss in doing some introductions for members of the public who might be viewing this. So I wonder if we could very quickly just whiz round. I will start by explaining why I'm in the chair. I'm Councillor Nicola Green from Bournemouth, Christchurch and Poole Council, and I am the portfolio holder, the cabinet member for COVID response, public health and education. Laura, would you perhaps follow on?
Yes, of course. Thank you, Chair. Laura Miller, Cabinet Member at Dorset Council for Adult Social Care and Health.
I don't know if everybody sees the screen in which, in the order in which I do, so if I may, I'll just very briefly say who people give names, and then perhaps you could give a brief introduction. Karen.
Good morning, everybody. I'm Councillor Karen Rampton, and I'm the portfolio holder for Adult Health and Social Care at BCP Council.
Claire.
Morning, I'm Claire White from Accountancy with Dorset Council.
Thank you, Claire. Kirsty, good morning.
Good morning, I'm Kirsty Hillier, Head of Communications and Lead Comms for Public Health.
And Sam, I'm sorry we didn't introduce you before you spoke.
That's quite all right. Good morning, everybody. I'm Sam Crowe, I'm Director of Public Health for Dorset and BCP Councils.
Sean.
Good morning, I'm the Service Manager for Finance for Adults and Housing for Dorset Council.
Catherine.
I think you'll find Catherine is making the outside broadcast service that she has the capability of doing that. So that's her job today.
Thank you, David. And you've already kicked us off and told us what to be doing. Perhaps you could explain your role.
My role is to clerk and administer the Joint Public Health Board. I'm from Dorset Council, but clerk it on behalf of the board.
Thank you, Vanessa, if you're there or whether you're coming in later.
I'm here, thank you. Hi, hello. Vanessa Reid, I'm the Director of Nursing and Quality at NHS Dorset CCG, and I'm the nominated CCG representative on the Joint Public Health Board.
Thank you. Nikki, are you there?
I am. Good morning, everybody. Hi, I'm Nikki Cleave. I'm Assistant Director of Public Health.
Thank you. Sophia.
Hello, everyone. Sophia Callahan, Assistant Director of Public Health.
And Jan.
Good morning, everyone. I'm Jan Thurgood and I'm Corporate Director for Adult Social Care and Health Public Health for BCP Council.
And I'm having a very apologetic moment, but I have a VB as well, and I do apologise. I'm not familiar with those initials.
That's Vivian.
Vivian, sorry. Thank you.
Hi, I'm Vivian Broadhurst. I'm the Exec Director for Adults and Housing in Dorset Council.
Thank you, Vivian. Apologies for that. So, right, we are back on the agenda then, and we are moving on to item 8. This is where my technology is way ahead of my capability. And that is, it's item 9, Sam, the Future of the Public Health Dorset Partnership. I'm presuming this is a paper for you to lead us off on.
Yes, absolutely. So good morning, everybody. You've had the paper in your pack. I was just going to talk around it and make a few brief points, given that we're going to get a bit of pace around the meeting today. So the Public Health Partnership was first established in 2013 on transfer of public health responsibilities to councils. And as we went through local government reorganisation and the creation of the 2 new unitary councils, we reviewed the service model with the Joint Public Health Board. The board was supportive of continuing with the shared service, and following that agreement, we updated the terms of reference. We put a clearer focus through those terms of reference on the board's responsibility to look at public health services, performance and monitoring of how we use the public health grant. One of the outstanding actions was to review the legal agreement, which supports the partnership, and in January 2020, I met with Section 151 officers and monitoring officers to look at the existing agreement. We were due to take that in the spring, but because of the suspension of the board, because of the COVID pandemic, we couldn't take that agreement through the board at the time. So this paper presents the new agreement for the board's decision. Just a couple of things to note. As I mentioned under the forward plan, what we would very much like to do is to move to more of a forward look around the financing of the shared service. So in advance of the new financial year, each year, we would like to use the board to agree the contributions from both councils into the partnership, and that will support using the public health grant, I think, more effectively. So instead of looking at returning money at the end of the year in a relatively unplanned way, we should be able to support the medium-term financial plans of both councils with a more proactive look at how we might use the grant outside of public health services. So I very much hope that the board would recognise that development. Both Section 151 officers are very supportive of that move. So I'll just present to you the paper and its recommendations today. Thank you very much.
Thank you, Sam, for that update. Any questions or comments?
Chair, if I may, I just have a comment. I just particularly support these recommendations, particularly around the finance annex development, because I think this is going to be a really welcome move for both authorities and for public health. So I'm grateful to the team and I support this.
Thank you, Laura. Anything else from anyone? I concur with you, Laura, absolutely, that this brings it into line to other financial planning that the councils do. I think it makes it a lot clearer for everybody to put it on the normal cycle. So we have the recommendations. Apologies. At this is page. Note to self: get quicker at this. The recommendations are on page about 25. Yeah. Apologies for that. And they are for the record.
Yes, they are. If I can just say, to accept the renewal of the shared service agreement governing the public health service across both councils, and to support the development of a financial annex each year that sets service budget requirements and respective contributions from partner councils.
Thank you, David, very much. Having no dissent and indeed enthusiastic welcoming, are we all agreed on that? Lovely, right. Thank you very much. Moving on to item 10, which is the finance paper. Sam, are you introducing this, or are we moving to the finance officers straight away?
Thank you, Chair. Usually I ask the finance officers to introduce the paper, and then I will join in the debate if needed.
Great, thank you very much.
Thank you, Chair. You would have all seen the finance paper in the pack. So just a couple of things to note. You'll note that from the previous meeting in June, the public health grant grew within 2021 by £900,000, taking the total grant to £28.7 million. The current provisional forecast is £1 million underspent, which is mainly due to the COVID-19 pandemic and the substantial changes that have taken place within public health services. Many of the partners have managed to adapt to services throughout the public health services. Many have adapted through redeployment of routes. Meanwhile, other public health services have slowed down and may not return to normal within the year. The public health team have played a key role in the local COVID response, and additional resources and staff have been working hard, and extended hours are likely to continue until March 21. Within the forecast, there is additional demand within BCP for drugs and alcohol services, and agenda for change for uplift for NHS contracts. The estimated full-year impact of COVID assumes a reduction in health checks and other community services, adaptation work to services to make them COVID secure, modelling and data science to support EPI cell work, and cost pressures within the team related to the COVID response. The forecast does not take account of the suicide and bereavement support, any changes in activity within community health services to either recover or reduce services during November following the second wave of COVID. To note, this forecast does not take account of any additional spend on local outbreak management plans and any of the additional track and trace grant received from MHCLG. And then just for the 2021 planning for the next year is based on the assumption that the public health grant will be the same as 2021. And as Sam had said, discussions are taking place with councils regarding retained elements and returns of any underspends.
Sean, thank you very much for that. That was a stop tour of a huge amount of work that's going on. And I'd like, if I may, just to make a comment, which is not entirely finance related, but it does need to be made for the minutes, that you've reflected somewhat in passing of the impact of COVID on the team and on the budget. But I'd just like to convey the thanks of members to the whole team for the response of the truly magnificent response of the Public Health Dorset team in supporting our communities through this year. The flexibility and the commitment to passing on the right communications at the right time has been absolutely outstanding. And David, I do wonder if we could find the appropriate way of not only minuting this, but making it a highlight of the board's recognition. Perhaps we might put it as an appendix in the urgent item so that it does stand out. But I do absolutely include the finance function in this, because there has been creativity and flexibility throughout the period. So my sincere thanks to you all. I think Laura and Karen may well wish to make some comments on that.
Thank you, Nicola. Just to add my thanks, really. I think we can all reflect on the last, year as being a very unusual one, and outstanding contribution and management by public health teams, just outstanding. I think Sam had his hand up. Is it gone away again?
I can put it back up again. Thank you for that, and I will pass that on to the whole team, because when this first started, it was perhaps a smaller core of us that were perhaps more used to health protection. But as the extended response has grown, we've drawn in more and more of the whole team, and they are almost all of them playing a completely different role now in supporting what we need to do around the acute response. I just wanted to make a couple of comments about the sort of the context around finance and what that might mean over the next year or so, because it'll be helpful when we come back to the board in February. My sort of assessment at the moment is that we're almost reaching the point where most of the commissioned public health services are relatively stable. We've gone through legal retendering of most of those services, and you'll hear around the last of those to be tendered was the sexual health service, and there's a report on that today. So it feels as if we've reached a relatively stable position in terms of the funding required by the partnership. And as Sian touched on in her introduction around the paper, the challenge in the next year is how we really start to grapple with these additional non-recurrent funding streams which are coming in to councils for the COVID response. So there's not only the test and trace grant, which we've been using to develop additional capacity, not so much within the public health team, but under the Health Protection Board, which has been very, very helpful in supporting the programmes that are being delivered under there. But increasingly, there's now a requirement under the Contain Outbreak Management Fund, I think I've got that right, which was announced to coincide with the new lockdown. This provides £8 per head funding to councils. There's a range of responsibilities wrapped up under that money, and some of them will relate to how we continue to develop our public health response to COVID, probably mostly touching on localising contact tracing and deploying rapid testing. So that's the sort of outlook over the next year, but I hope we'll bring a fuller paper to the February board when we're agreeing the contributions to the partnership, but I just thought it'd be helpful to add that note. Thank you.
Sam, thank you very much for the update. Karen.
Yes, thanks, Nicola. I just wanted to echo what yourself and Laura have said, and thank you to everybody who's been involved. Speaking to various people in adult social care, I think that some officers are absolutely almost on their knees with this pandemic, and they're going way beyond the call of duty. And I just want to acknowledge that we do recognise that, and we thank them. And it is not going unnoticed just how much they're putting in and how they're going way, way beyond what we might have expected of them. So yes, just to add my thanks.
Thank you very much. I think in the comments we've made, we have noted, as we were asked to do, the situation currently on the finance paper, and we look forward to the further updates coming through. Sian, thank you very much for your work and that presentation, and we look forward to the update. Thank you. So we are now at, all right, I'm getting faster at this. We are now at item 11, which is the clinical services performance monitoring. Sam, I think we're starting with you again.
As Nikki Cleave and Sophia Callaghan are here, I was going to invite them to comment on the clinical services performance. They'd probably do a far better job of it than myself. So, Nikki, over to you first.
Morning, everybody. Shall I start with the drug and alcohol? I won't labour it because I think actually the bullet points that you've got around current issues are fairly clear. So still we're seeing increasing numbers of service users engaging within BCP Council, which is welcomed and really good news, but of course puts additional pressure on services who are now delivering care to a lot more people than they were commissioned to do. We're going to talk a little bit about recommissioning a little later, but obviously that gives us an opportunity to think about the way that we're using the existing resources and try and sort of modify services to be more effective for supporting people. We are unfortunately seeing some negative impact of COVID-19, not surprisingly, on outcomes, so particularly around alcohol, because of course things like detoxification services have been very challenging to offer both community and residential detoxification during this whole period because of the problems that we've got with actually offering face-to-face contact with clients. So we are seeing some issues with that. We're hoping that as restrictions hopefully start to lift over the next few months, that we'll be able to catch up a bit with some of the outstanding detoxifications that we need to offer to existing clients. There's a comment then around alcohol-related hospital admissions, but I think we've talked about in the past, and the very welcomed improvements that we've seen around BCP in improving performance around hepatitis C. In particular, there's a national programme around elimination of hepatitis C, and there's been an awful lot of proactive work done by commissioners in BCP Council to try and increase the identification and get a greater number of people into treatment. And we're now starting to work with CCG colleagues around their plans to do similar work with a primary care population. And drug-related deaths, just to highlight, to recognise that obviously that's an ongoing concern, that we have seen increases over the last few years. We're monitoring that very, very carefully at the moment. So we not included in the paper, but we monitor drug-related deaths on a monthly basis and compare them to the previous few years, what we've seen in months. And we're looking at every single death in quite a lot of detail to try and assess whether any of the service changes that we've needed to make because of the pandemic are having a negative impact on service users. But anyway, I think that's what I wanted to say, and I'm happy to take any questions.
Thank you, Nikki. Questions, comments from members? Karen.
My hand down. Yes, thank you, Nicola, and thank you, Nikki. Just a question on the point that you made about the alcohol-related hospital admissions, and particularly for the BCP area. If there is an impact, and obviously there will be an impact because the hospital numbers are rising in terms of COVID admissions, what's the sort of fallback position for people with both alcohol and drug-related issues who can't be admitted to hospital? What's the plan?
So we have people obviously continuing to be seen who are in touch with our treatment services. So our treatment services are obviously focused predominantly on people with quite significant alcohol problems, alcohol dependency problems. Much of the alcohol admissions that we see there will not be those people. That a proportion of those will be related to the wider community use of alcohol. So all of those services in place. The challenge that we've got is that we can't offer them residential detoxes in the way that we would do as part of their standard care, where people are dependent and need to go through a detoxification. We don't really have a solution for that other than supporting them to try and do managed reductions in their own personal alcohol. And for some people that will actually work. So you support them to over time reduce their alcohol. So we do see some successes with that approach, but detoxification would remain a good option for a proportion of them. And that at the moment is the challenge. We don't really have a way of mitigating that at the moment.
Thank you, Nikki. I can't see any other hands up, but I have a couple of questions as well following on from Karen's, and I think they might be quite different, but I'll ask them both together because you may wish to wrap them up. The first is, have we, that was kind of a looking forward, looking at the present response, and I suppose I'm looking back to the Everyone In programme earlier in the year. I'm wondering whether for some people who found it really hard to get into settled accommodation, and one of the reasons for that will be through addiction or dependency issues, whether you have any view, it's probably too early for any evidence, as to whether that has helped a cohort who perhaps we weren't able to assertively outreach to. Not to say that the your regular services wouldn't be assertive in their outreach, but this is a very different programme. So there's that question, and then on a separate note, going back, I think, to the thing that sits slightly before Karen's question, is that have we noticed any impact on self-referral into services over the COVID period? We were aware that there was some drop-off in people seeking other medical health support early in the pandemic, and I'm just wondering, as a note really, as to how we might go forward in our communications, as to whether we noticed a drop-off in people coming forward for services through the earlier part of this year.
Okay, so if I take both of those questions, so the first one around accommodation, I'm not aware of any evidence that we've got at the moment of what impact that would make in terms of outcomes and engagement. We can certainly look at it, but what I would say is that stable accommodation, we know, is a key factor for people with substance misuse. It's one of the key factors that will help them to engage and help them ultimately to make some changes to their lives. So we know that stable accommodation and job ultimately, and if we go back to sort of that whole thing about house, a job and a friend, those are the things that can often make a difference to people. But so stable accommodation, really, really important. So the ongoing work that both councils are doing to try and support people and maintain people in stable accommodation, really, really important to helping this cohort of patients, and really very, very supportive of that. The second question about self-referral, I don't think that I necessarily, most of our referrals would be self-referrals, because we encourage people, and GPs, secondary care would often encourage people to make that personal step to refer, because obviously there is something about them being ready to make changes to their lives. So a lot of our referrals would be self-referrals. What I can say is that we continue to see a steady increase in referrals despite the pandemic. So those numbers are continuing to increase, particularly in BCP. So we've got a far more stable population in the Dorset Council and Poole Council area, and that's reflected throughout the figures. But certainly for the Bournemouth area, we're continuing to see a steady increase. And it was Bournemouth where we had concerns that there were too few people in treatment previously. So that's still very welcomed, but those ongoing pressures on services, as we talked about.
That's very helpful, Nikki. Thank you for that response. So I suppose that's something that we would like to keep an eye on as those figures become, as we are able to monitor outcomes and uptake as well. Thank you. I can't see any other hands, so I'll take us back then to the recommendation that I think we have considered the information in this report and noted performance. And if we can just kind of, I'm assuming we will monitor this through the forward plan. In terms of, everybody's happy, we'll move on to item 12, which is sexual health. And who have we got speaking to this paper? Jump in, whoever you are.
Chair, I think it's Sophia Callaghan will take us through this paper and perhaps also note current services performance as well in brief. Thanks, Sophia.
Thank you, Chair. Thank you, Sam. I'll start with performance, I think, because that was just on the end of the clinical report, if I may. So it's just to say that it's just a look at STIs over the last few years and the trends, and it's just to say that relatively Bournemouth, Christchurch, Poole and Dorset have been relatively static and below England average. The diagnosis of chlamydia screening is slightly higher in BCP, but that's because we actually test more people. We're very proportionate in finding the positives in BCP, so it'll be higher in BCP than Dorset, where the positivity rates are much lower, and the rates of chlamydia diagnosis above 25s remain below the England average. What we do have is a rise in gonorrhea and syphilis, which is reflected nationally, but we're still below England average for gonorrhea and slightly above in BCP for rates of syphilis. So we've been working with PHE looking at how we improve comms and promote better awareness in terms of self-management, care and prevention approaches. HIV diagnosis, we don't have any new data in yet, so this reflects 2014 to 2018 data, which again we're slightly above prevalence to nationally in BCP, but we are one of the higher rate areas. And again, new diagnosis is falling, although it's just above the national average. So I'll pause there. The under-8, good news, the under-8 in conception rate has fallen up to 2018, quite significantly from 2017, which is good, and remains relatively static in Dorset. So I'll pause there for any reflections and comments on performance before I move on to the mobilisation report.
I can't see any hands up, so perhaps if you could do that, then we'll, if they come back, if the questions link into that,
okay,
all together. So thank you.
Thank you, Chair. So the next report again is to note the successful joint procurement and award to Dorset Healthcare of the integrated sexual health and HIV services, and also to note the additional COVID measures and the phased recovery planning. So if I take you through the paper, this has been a long journey, and as many people with the history know, a long story in terms of how we've worked collaboratively across very different services that historically were very fragmented and worked alongside each other. So partners have been working hard to look at see how we can collaborate and start to mobilise an integration prior to tender, which we managed to deliver in sort of parallel with COVID and elections and PERDA and all sorts of things going on at the time. So we extended the contract for 6 months to give us plenty of time to work with NHS England to provide a joint procurement with separate contracts so that we could really integrate the sexual health and HIV services. So it's a much better outcome for patients attending the service to get the right professional at the right intervention at the right time, rather than sort of referring and then signposting on and referring back again. So we awarded in October successfully to Dorset Healthcare. They've moved into the community setting a month or so ago, very successfully and in line with the previous plans, even though they were at the same time making themselves COVID secure and working to deliver sexual health services to priority groups during the whole of the COVID period and the lockdown. So I'll pause there. I think, as I've said with regard to COVID, the service stayed open for emergency responses and made sure they covered and worked with priority groups. Vulnerable groups such as sex workers, again, we developed a COVID secure response where we were either virtual working or working from mobile van services. So I'll pause there, Chair, for any questions.
Oh. Nearly went horribly wrong. Apologies. Sorry, that was you. Are you sure you want to leave? No, really, that was not the button I was after. Sorry, Laura, I was trying to invite you. Apologies.
Thank you, Nicola. Yeah, just a comment more than a question, really, to note the huge amount of work and the achievement in going, moving and doing all of those things whilst being COVID secure. And it's kind of a very quick remark, isn't it? Whilst being COVID secure, it doesn't really take account of the huge amount of work that is required to do all of that. So a comment on that, and just to note that I'm particularly sort of interested in the phased recovery and how that pans out and how we keep updated on that, because I think that coming out of this year, I won't say coming out of the pandemic because we're not, but coming out of this year, how our plans change, develop and recover I think not just for this item, but I'm saying it to this item, will be a really, really interesting and vital piece of work that we're really going to need eyes on. So just a comment there, but thank you, Chair.
Thank you. Karen, did you want to make any observations here, or are you happy that we move on?
Nothing at the moment, thank you, Chair.
All right, thank you, Sam.
Thanks, Chair. Just a really, really quick comment from me. The paper probably doesn't do the progress justice, actually, because those of you who've been connected with the Joint Public Health Board may remember that we've tried to tender this service legally on a couple of occasions in the past. And I think the fact that it was successful this time around is testament to the work on relationships that's gone on between all of the providers. And I can't underestimate enough just what a transition it's been to pull people out of hospital outpatient settings, which is where genitourinary medicine regularly took place. We used to pay completely over the odds, in my view, for attendances under a hospital tariff, which was completely inflexible and would cost us upwards of 7 million potentially across the Dorset system just a few years ago. So to come out now with a lead provider model being led by community services and to shift to a prevention-oriented model in the community with a capped contract. I think you'd see from the paper that the contract is now capped at around 4.8 million. It's a huge amount of work that Sophia's managed to lead, working through Dorset Healthcare and across those acute trusts. So I'm just really pleased to see this. And surprisingly, the most difficult step was actually working alongside NHS England to get that joint procurement approach. It was far from straightforward to align the retendering of those two services. But as Sophia said, it's so important that they stay together, because it's a difficult thing for councils to commission part of the sexual health services and for the specialist HIV services to continue to be commissioned by NHS England. But we did it, and I'd just like to flag all of the work that's gone on, because it's a good piece of work. Thank you.
Sam, that's really positive, thank you. And Sophia, I know you want to respond, but before you do, could I just pick up on the comments that Sam made about the very positive effect, the impact of having that service as a community-based one. Could you just say a little bit about how that will impact on the user of the service as well, for it not to be a hospital-based one?
I think being community-based, it's right out there in the community. It's easier to access. You can have direct access. I think it'll be easier to get to than going over to what used to be Royal Bournemouth Hospital. I think we've got a hub and spoke model, so we've got a model now that could be more responsive and flexible to meet the needs. It's a purpose-built unit. You've got GUM consultants and nurse prescribers and nurses and healthcare assistants all in one place. So in response to Laura's comments, some of the benefits that have come out of COVID is partly, they're all in the same building, which is brilliant. You don't have to sort of see a nurse and refer on. We've got GUM clinicians just seeing the most complex patients, so it's been really efficient and effective with their time. We're skilling up nurse leads and practitioners that can do a lot of the work. And we've also got healthcare assistants which are doing the behaviour change. So we're doing much more emphasis on really embedding behaviour change throughout the service, whereas before it was a test and treat with incentive for payment by results, almost a perverse incentive. And I think some of the changes, we've started doing clinical triage as opposed to administrative triage, which means that clinicians speak to people to assess their risk, assess their situation, assess their vulnerability. So the DNA rates have dropped quite significantly because they're being slotted in to see the right person, whereas an administrative triage was you just slot into a booking appointment. So we've got some real benefits. Although the clinicians will say it's taken more time to do that for every patient, it's actually been much more efficient and effective way of working digitally. We're also online now, which we weren't due to be until the start of the new contract, but it was mobilised really fast and really quickly with SH24. And we're seeing the benefit there, where we're taking what we call people that just want a checkup or a test. They don't need to come in, they don't need to see a clinician, take up a half-hour appointment. So there's really some good benefits that have come out of how we work differently in terms of the face of COVID and how we've mobilised a lot of the stuff we wanted in the contract very quickly as a response to the pandemic.
That's fantastic. Thank you for that. Vanessa.
Thank you. Sam and Sophia, I think one of the things I just wanted to pick up on, and I think you've touched upon this, is it always makes me a little bit nervous when there's a reduction in or there's an efficiency. I just wanted to check that the reduction in the grant is all around the efficiencies and that there hasn't been a reduction in services. So I think it's a really important sort of clarification confirmation point for the board.
Thanks, Vanessa. What we've done is there were many inefficiencies in terms of DNAs, patients that just could have seen a nurse, seeing a consultant. By capping the payment by results meant we paid for every single test, whether it be needed, required. It's the only service where is direct access. People can just walk in. So what we've done is we've triaged more effectively so that we're using the online more effectively, so people don't need to come in. So we've managed to move and change around services so we keep the quality and we keep the effectiveness, but in a more efficient way. So we've got maximum use of clinics, DNAs are dropping. So we've actually been able to mobilise better with the money that we've got. And because it's a block contract rather than so much money for, we've integrated over the rainbow, so that's not a separate unit out there, and people are happy with that. It was done with a lot of consultation. We've moved around clinics that weren't really effective, but ensured we've got the clinics in the right place. And part of the recovery plan will be to start to open, we've opened one satellite, I think now. We're going to start to open the other satellites as we get back to recovery and back to normal, which is part of the phase 1 of the new contract anyway. But no, Vanessa, what we've done is just really tried to work with providers to ensure that we remain with the quality, we remain with all the guidance and the standards, but we're just working in a different, more effective way, I'd say.
Vanessa, that was a really helpful challenge. Are you content with the response?
I am, yes, thank you. I was just going to put something in the chat. Yeah, I think it's helpful that so far it's confirmed that the standards of performance and quality will be maintained. So really helpful. Thank you very much.
What we've done actually to add, Chair, is we're just going through the performance scorecard for the new contract, but what we're adding in to even dig deeper with regard to quality is we're setting up annual audits and annual deep dives. So if we see anything in the performance that might be natural variation or normal, we're digging a bit deeper, and we're doing these audits throughout the year. So I'd be happy each 6 months, whenever we do the report, to feedback on those, and we're working every 2 weeks with the team. If they see anything that's they're not sure about, then we will look a bit deeper. So we're very open and very transparent as we're sort of mobilising year 1. So I'm happy to feedback, Vanessa, on the different sort of quality measures that we've decided to put into place. And not only for sexual health services, we want to work wider. So how is the sexual health service working with school nursing? How are they working with the wider factors? We've touched on housing before, we've touched on safeguarding, we've touched on all the different areas. You know, how are we thinking about that person as a holistic person, especially if they're young people, in terms of their needs and meeting their wider needs?
Thank you, Sophia. And this puts me in mind of how the Children's Services approach, which is always to listen to the voice of the child. And I do wonder whether perhaps in some of our services more generally, I'm not asking for anything to be done that isn't done already, but you will be collecting some sort of evaluation and hearing from people who have accessed the services, whether at some point the Joint Public Health Board might want to perhaps just append in a very light touch way a couple of case studies and hear about the experience of people, because I have to say, hugely enthused in the idea of giving people the service at the point that they want it, which is in the community and early on, and seeing the right person. You mentioned seeing a nurse when you need to see a nurse and not necessarily going further into the process. So I find that a very positive approach. So it's just one perhaps for us to bear in mind as a Public Health Board for the future. As I say, not to add a great deal to anybody's reading, and certainly not to make busy people even busier. But if those stories are being collected elsewhere, perhaps we might want to give a bit of light to them. Okay. Karen, I'm sorry, you've been waiting.
just to unmute Councillor Rampton.
Sorry, I turned my camera off and I turned myself on to mute as well, I think, at the same time. It all sounds very positive. Thank you very much for all the work that's been done. My question really, and apologies if this was covered and I've missed it, is about communication, because there may well, especially during a pandemic, there may well be a lot of people sitting worried at home and actually not even realising that services are ongoing during lockdown. So how do you communicate, and are you able to sort of target particular places? And I'm saying universities, and I'm not trying to sort of say that group is more likely to have need of the service, but what is done to communicate to people that the service is there and it's ongoing during the pandemic, and don't sit at home and worry, please seek help?
First of all, the primary care are well aware of the service. We've pulled it down from many different numbers to one number. Part of the digital solution is a more interactive website where they can call in for consultation. They can get self-care information from the website. We've done social media. We've got a lot better and wider in terms of different social media platforms. We work directly with the university to make sure that there are services that students can access. So we've done consultations as part of the change. So we've worked on different levels of media methods. We've also got outreach team that work with the schools. So they've been able to be more responsive, working with the school nursing team to have a look at the needs and the communications of how we ensure that the service has stayed open. But I can give you a more detailed information, Councillor Rampton, if you would like it. But what we've done is work on different, as I say, different media levels with different communities and different groups to make sure people are aware that it's still open. And it stayed open the whole time.
Thank you, Chair. That is reassuring. I just wondered if there is something planned just at the beginning of this lockdown, just a social media sort of message that can go out just to say we are still here and please seek help. I wonder if that would be something that could be considered.
Thank you, Kirsty. I'm not sure if you're still on the call, but certainly I'm happy to take that away if she's not, as a note for to mention to you, Kirsty Hillier, because I think, and I hope we recorded it earlier in the meeting, but the Public Health Comms team have been immensely effective through getting the right messages out. But Karen, you're absolutely right that we need to make sure that people are aware of the business as usual. And we have just had a comment through from Kirsty about targeting the particular groups in this. So we'll just make sure that that is followed up. And checked out on. We won't create more activity if it's already ongoing, but just as a note out of the meeting to give you some assurance, I hope. I think we have, in terms of the recommendation, not only noted but commented on the service. So if everybody's content, we will move on to item 13. Now, is this one for Joanne coming back into the meeting?
Yep, good morning, colleagues. So Jo Wilson, Head of Programmes here. So you will have received the paper just providing an update on our Children and Young People's Public Health Service. This was tendered, and this is an update on the year one of the new contract, which started last October. So what I've provided in the update really tells you the journey that we've been on this year, and it's been a very unusual year, as you'll appreciate, for mobilising a new contract and a different offer. But in the first part of the contract period, we've had some really good progress. We had some really good progress against some of the key areas of work that we identified that we wanted to deliver through this new contract. We had some key objectives around smoking, physical activity, emotional health and wellbeing and school readiness, and we saw some really good progress made around those, linking our Children and Young People's Public Health Service with a range of partners in local authority, primary care, etc. So those are there to note in terms of the the achievements. We continue to see really good delivery of the mandated checks for children aged 0 to 5. So that's the 5 key contacts. We continue to see performance above England and South West averages, which is really, really positive to see that that continued. We have seen some pieces of work that I wanted to highlight around rolling out programmes and training for smoking cessation and using CO monitors, and this is around improving the pathway from our midwifery colleagues through to our health visiting to help people continue to stay quit. Our school nurses worked in partnership with the Head Teacher Alliance around PE and sport and primary care networks to improve and promote physical activity for children and young people school aged. We've had good developments around clinical pathways and System 1 tools for particularly around perinatal mental health. And again, what we're looking to try and achieve through this contract is really knitting the pathways better together right the way along things from maternity through to our health visitors and through our universal and specialist services. The service did quite a lot of promotional work, as you see there, from schools to primary care, paediatrics, local authority, just to address what the new offer looked like, what the focus was of the service and how it was going to work with those partners to achieve that. Of course, we then entered into the period that brought in around prioritisation due to the COVID pandemic, and guidance was issued around how community services should prioritise. We worked very closely with both the service and with colleagues in the local authorities to again look at where we needed to prioritise joining up the services and be part of the partnership that had eyes on our children and most vulnerable families. One of the things that we have seen that we I guess has been an interesting balance of working in a new way is around the acceleration of the digital work that the service were looking to achieve. So that's certainly been brought forward. So we were intending to see more digital work, more a reach out to parents digitally, and we saw that as a result of the COVID. So that's been a positive step, an opportunity in this period. So this is around using text message services. We had a good text message service for children through Chat Health, but equally looking at platforms like Attend Anywhere, so children and also parents could access support, advice through kind of online virtual consultations, and that's worked really well and has accelerated the progress in terms of how we wanted to see our health visiting offer move forward for our universal families in particular. Chat Health continued to be busy and was an important access point for children and young people. As you'll appreciate, and I'm sure you would expect, there were a lot of traffic around emotional health and well-being support, and the service was part of lots of networks and forums that we put together over the summer holidays to prepare for meeting the needs of children returning to school in September. The National Childhood Measurement Programme did stop. However, we recognised that the delivery had achieved the vast majority of the measurements. So only 2 schools in BCP and 2 schools in Dorset didn't have measurements uploading. So we feel that's a really positive step forward, certainly different from other areas across the Southwest. And we have now started to see some of the information coming back from that programme around those measurements, which is good. We then entered a period around restoration, of course, then looking again at how we stepped back up some of those services, and the work that had continued around statutory and vulnerable carried on, but looked to step up where we could, increased around that. New baby visits face-to-face were reintroduced universally, as well as 6 to 8 week contacts were brought back online, as well as face-to-face where identified vulnerabilities were there. There was a stratified provision of year 1 contacts, so we recognised that we wanted to very much prioritise those early contacts, and then the 2.5 year contact based on our commitment around school readiness was prioritised for catch-up. We're now entering next week and the following week 2 really positive opportunities that were identified through the stakeholder engagement process. to have an annual conversation. So a really dedicated opportunity outside of the different strategic forums that are available for us to do that partnership work, but really dedicated opportunity to look at this service on an annual basis through the lens of partnership. And we're using the science of safety principles, and I appreciate that's also aligns well with the Dorset principles around strengthening services and using a strengths-based model. So we'll be looking at the different outcomes that were identified for this service through the kind of what are we worried about, what's working well, and what do we need to do next. And this is just a really good annual opportunity to review as a partnership and continue to ensure that the service remains agile within the needs that we identify as a system. So they're taking place, as I say, over the next 2 weeks, and we look forward to joining with our partnership colleagues to have that dedicated opportunity to really drill down into what we've achieved in year one and what we need to do over the next 2 years as part of the first 3-year element of this contract. And take any questions.
Thank you, Jo. Any questions from members? Karen.
Thank you, Chair. Yes, thank you for that. Interested in the chat. Well, first of all, first part of my question really is, does this include people with disabilities, especially with learning disabilities? And the second part to my question is, I'm very interested in the chat health, and but how accessible is that if it is a younger person with a learning disability? And I suppose the third part is, do you sort of link up with the People First Forum, for example, and other sort of self-help groups who can help guide people through accessing information confidentially?
Yeah, thank you very much for your questions. I'm sure the service is very much engaged with around those learning disability forums, and I will ensure that we feedback and invite them to share with us how they're working on those. In terms of the chat health, I think this is one of the projects that we felt would also lend itself to young people who are not necessarily in mainstream school, or young people that actually may find a kind of more digital option more accessible actually. So Chat Health has been running for about 2 years now. We piloted it. It was part of a national scheme, and our local service has actually been part of some really nationally recognised podcasts that sit alongside that text message service. So it is very well accessed by young people. It's aimed at those 11 to 19, so it's our sort of secondary phase age students that are encouraged to use it. It's very well advertised. We certainly did a lot of digital work with our comms team to support Dorset Healthcare's digital strategy around getting those contact details out to young people to make sure they knew that that service still was available to them. It was also backed up by some of the Attend Anywhere that I mentioned. So where young people perhaps text in and through risk assessment, it's felt that a more face-to-face or a more enhanced offer would be beneficial to a young person. So this might be, especially where it comes in around an additional learning need, then an Attend Anywhere approach could be used. And so that is as we're using this kind of face-to-face digital approach, we've seen that be really successful.
Thank you, Jo. I can't see any other questions popping up. I suppose I'd just like to comment that we were very conscious through the first wave of the pandemic, but the principle applies now, that we know what we know about many of our children, but that we don't know what we don't know. And that is something which I think is still on everybody's minds. You know, people are using very best endeavours to get there, but I do wonder whether we can just keep an eye on this when we monitor it going forward, that we need constantly to ask ourselves, are we missing groups? And thank you for the work that you've done and that you've expressed about going to those harder to reach groups. But I think we constantly need to bear that challenge in mind going forward. So thank you, Jo. Vanessa.
Thank you. Yeah, I just wanted to support what you've just said, and what I really welcome the approach that Jo's taking with the annual conversation. I think that would be an ideal opportunity to have those conversations and check in the peculiar set of circumstances that we've had over the last several months, and give us an opportunity to sort of reset if necessary. So I welcome that. I think it's a really good idea, and obviously we would be really interested in the Public Health Board to see the outcomes of that as well, I'm sure.
Thank you for that, Vanessa. So, Joe, thank you very much. I think we, going back to the recommendations, we happy to note and endorse the progress in year one and those challenges. Do we need to add something to that? Just a bit of wording about look forward to receiving further updates as they become available. Perhaps with a specific note about Vanessa's last comment. Members of the board happy with that? Yeah, great. Thank you. Thank you so much, Joe, for that presentation and of course everything that sits behind it.
Thank you, much appreciated.
That takes us on to item 14, which is the commissioning options for drug and alcohol services, and this is particularly relating to BCP, but I'm sure it's of interest to the board. Thank you. Sam, is that one for you?
I'm going to ask Nikki to talk to the paper and then I'll join the discussion as we open it up. Thanks very much.
Lovely.
Over to you, Nikki.
Nikki.
Okay, thanks. I think the first thing I wanted to say was just, although my name's written as author, this was a paper that was written jointly with officer colleagues in BCP Council, and I'm delighted that Jan's here because she may well want to contribute as well, as Jan was very central to the conversations around this. So the paper, I think, is self-explanatory and identifies some of the ongoing challenges that we've got in the BCP Council area, which I referred to earlier when we were looking at performance around the increased demand and some of the budgetary pressures that we've therefore got on services, both around numbers of people and then the associated prescribing costs, and some of the inequity in provision that we've currently got because of the historic arrangements between the legacy councils and the way that budgets were allocated. So we've always been of the opinion since BCP Council formed that it made sense that a single set of commissioners would take on responsibility to allow some of those issues to be addressed. And we've obviously been in conversations between the public health team and BCP Council officer colleagues around the best fit as we move forwards. The paper basically outlines the proposal that from BCP Council that they think that the best fit for them is to take full responsibility for the commissioning of those contracts moving forwards. And I think the key question for the board is really what the implications of that will be as we move forwards when the public health team continues to commission all of the drug and alcohol services for Dorset Council around both decisions around commissioning and performance monitoring. So I think, you know, there are some questions that would then sit around how we want to work moving forwards around the drug and alcohol agenda. I'll then defer to Sam and Jan to add any additional information.
Nikki, thank you for setting that up. Jan, I saw your hand first.
Thank you, Chairman. I just wanted to comment that on the fact that both teams commissioning drug and alcohol services bring a lot of expertise to that process. So where we needed to get to was to establish the lead. What I would want to be saying is it is critical to have public expertise, health expertise in the commissioning cycle. So that we are continuing to discuss how we ensure that happens, because I think that's absolutely critical. I think one of the issues that we were concerned to do was to really see, and we've had a conversation earlier about people in the round, so to do more work to join up commissioners who may be commissioning things that impact on people's lives from different points of view. So we wanted to enable people with complex needs so that we could better commission for their whole lives and not just one component part. So that was part of the decision making, but I did want to emphasise that having public health expertise in the commissioning cycle is absolutely key. And some may want to comment on proposals so that this board has an overarching line of sight on some of the public health aspects of this area across both council areas.
Thank you, Jan. Sam?
Thank you, Chair. Thank you, Jan, for those comments. It's really helpful. So I guess my comment about this paper would be that I think it's really good to have clarity. I think that's really important because, as the paper shows, there perhaps was confusion at times. Providers didn't quite know who they should really be listening to most because of the mixed model. I fully support Jan's comments about the importance of retaining some public health involvement in the commissioning cycle, but that doesn't mean that we necessarily have to be involved in the whole of the cycle. So I think without solving it within this board, we need to come back to the board with a set of proposals around the governance and oversight of both drug and alcohol services. One suggestion might be that the contract monitoring and performance elements would go to respective cabinets, but that the Joint Public Health Board would retain oversight of the sort of outcomes and the population health metrics in relation to drug and alcohol. But we need to probably come back with a clearer set of proposals around those. I think it's just recognising that in the past we had a Pan Dorset Drug and Alcohol Governance Board. Not sure if I got the name entirely right, but the board was dissolved with the understanding that the Joint Public Health Board would then take on that function. So if we're going to change the commissioning responsibility, we just need to make sure that we're doing the right sort of scrutiny in the right place, and to make sure that respective councils have the ability to challenge appropriately where they want to perhaps develop that model. That sort of whole life commissioning model, I think, will become increasingly important. So those are my comments. Thank you.
That's very helpful, Sam. Thank you. Any other comments from members of the board? Nothing. Can I then, and David, I would appreciate some guidance if this is acceptable. Perhaps in agreeing the recommendations as they currently are on page 73, should we note and agree the proposal for BCP commissioners to take on the core responsibility, and then either as a separate recommendation or as a further as an addition to the second recommendation, which reads to consider the impact of this on future oversight of drug and alcohol service performance and commissioning decisions of the board. We are a bit more explicit about retaining the line of sight from the Joint Public Health Board and receiving a paper or an amendment setting out some clarity around the future governance of the arrangements. So does that broadly pick up on the comments that you and Jan were making, and would that get us to where we need to get to?
I think so. I'd support that, and we could probably, if members are supportive, bring an outline proposal back in between. We don't need to wait, I think, until the February meeting. We could perhaps submit a paper by email for board members' consideration, just to set out some options around that.
I think that would be very helpful because, as you say, we don't want it to wait for a number of months. But I think we all know what we want it to look like, and it's just putting that in one place and then perhaps formally adopting it at the next board meeting, but not letting that hold up any forward movement. David, is that acceptable to you?
It's certainly acceptable to me, and a practical advancement in terms of what we're trying to do.
Brilliant. All right, thank you so much for your support in minuting that. So that takes us from those recommendations, and thank you to Vanessa, who has pointed out that in my enthusiasm to get going, I haven't dealt properly with the minutes of the last meeting. Vanessa has pointed out an addition which needs to be made in terms of attendance, but going back to where I should have started, are there any further questions or comments about the minutes of the last meeting? I think much, as far as I can tell, everything that came forward as a matter arising has been dealt with, but let me start as I should have done and invite comments on that. Sam.
Thanks, Chair. It's related to the minutes and the first item that was on the last agenda, which was a verbal update around COVID-19. In my current busyness, I failed to notice that we didn't have it on the agenda this time around. So I was just going to ask board members if you wanted a very quick 2 or 3 minute summary on the current situation. I was particularly going to draw out what the public health team's been doing, as this board is concerned with the oversight of Public Health Dorset. So
please do. There are lots of nodding heads, and
yeah, okay, no problem. So I will.
It'd be lovely to know what's been going on.
No problem. So I'm going to try and share my screen, and then I'll bring up a couple of slides. There's not many. You'll be pleased to hear, hopefully. So I'm guessing you can't see that because there's no red ring around it. Bear with me a second.
I'm not too sure that the arrangements for outside broadcast are quite the same as, say, a team live event where it goes. We've got something.
I've got something indeed. Seems to have worked this time.
There.
So I'll run through this very quickly. I guess the first thing I'd like to highlight is some relatively good news, which is the data just in this morning shows that the 7-day case rate for BCP Council has dipped below 200 cases per 100,000. We were concerned because obviously it stepped up significantly over the past 2 to 3 weeks. But it's great to see that coming down below 200 cases per 100,000, and Dorset as well, just inching below the 100 cases per 100,000 population mark. So suggests that maybe we won't continue to see those rather rapid rises that we saw 2 to 3 weeks ago, which were extremely concerning. Southwest at 145 cases per 100,000 on average, and England at 228 cases per 100,000. Just in terms of the current pattern, the age profile is still predominantly infections in younger age groups, but the measure that's causing concern both regionally and nationally is the rise in infection rates in the over 65s. This is what fuels admissions to hospitals in part. I've put down there that there were 107 people in the Dorset hospital system with COVID the last time I checked, but I'm aware that there may well have been an update since I looked a day or two ago. One of the pieces of work that we've been doing through Epicel is to try to model and project forward over the next couple of weeks what that might look like, and that's been doing the rounds across system meetings. I think it went to Health and Care Silver this week. The implications of that work are that there's not a lot we can do about the current trajectory over the next 2 weeks, because it's set by the infection rate that was in our community 2 to 3 weeks ago. And that shows that by November the 9th, I believe, we'll probably have exceeded the number of people that we had in hospitals in April. The big difference this time around is, of course, we were unable to decant people from hospitals into the wider system. So the NHS is trying to do a lot of catch up currently through the phase 3 recovery programme to try to keep eating away at the backlog of all of those people who were denied essential care during the spring. So it's a very delicate balancing act at the moment. I was then just going to give you a quick summary of what the Public Health Dorset team's been doing, as this is the joint board. Since we last met, we were briefing the board about the development of the local outbreak management plans. They were signed off late June, early July. Since that time, the team have been linking through the Health Protection Board with colleagues across the system to get the action cards and operating procedures in place for those high-risk settings. Lots and lots of incident management work connected with supporting care homes and schools. We've continued to build the support around what we call Epicel, which is the epidemiology cell, which meets weekly. That team now deliver weekly reports to the wider system. So they go to the Health Protection Board on a Monday, and we use that report to really flag the main themes to then feed other cells that are looking at enforcement activity, but also it provides us with an understanding as to where we should be targeting our comms and our community engagement efforts. So really, really important that we continue to support that cell to function effectively, and the intelligence team in Public Health Dorset is a huge part of that cell. So the Health Protection Board, I've mentioned, it was an early stage of development when we last met as a board, but it's now finding its feet. We have a programme manager in place, Sarah Longdon, who's been really effective at getting more discipline into the board on a weekly basis and driving that production of regular reports from all of the cells that report through the Health Protection Board. And the weekly sit rep from the Health Protection Board, I've heard, is increasingly helpful, and it's used in many system meetings now to just keep partners abreast of the most important developments. The board also is responsible for something that I think is going to be increasingly important, which is a longer term programme of work called Contain and Enable. So a lot of the public health team work alongside the Public Health England regional health protection team and council colleagues in maintaining that acute response, but we need to be able to stand up our longer term programme of work to contain and prevent COVID. So a lot of live discussion at the moment around how we stand up a longer term strategy, which is our Contain and Enable strategy. Three important strands of that are likely to be continued work on communications and engagement, but underpinned by a much better understanding of behavioural insights. So people know what they need to do, but increasingly we're finding very, very clear evidence that there are barriers to people complying with those measures. A couple of examples spring to mind. Self-isolation. Not everybody self-isolates, even though I'm sure most people at least have a basic understanding that they shouldn't be going out and meeting people if they have COVID. But nevertheless, there are some groups that continue to do that. And I think access to testing as well, because of the difficulties in obtaining tests locally, I am concerned that maybe people have sort of given up in some instances of getting a test. And there's a gap that's emerged between the actual numbers that are being tested nationally versus the estimated number of people that have COVID through the community seroprevalence surveys. So the national estimate is that perhaps only half of people are coming forward for testing. That's obviously a concern. And it could actually explain the increases that we saw over the past 2 to 3 weeks across both councils. So although we'd had universities returning and schools going back, we saw a continued step up in infections, which coincided with a period where it was actually quite difficult to get a test locally because laboratory capacity was being reprioritised to serve harder hit areas in the north. So that's possibly one of the reasons why we saw that increase in our local infection rate. So pushing testing is going to be a huge part of that strategy. So I've just highlighted some of the new developments coming on very rapidly. We've got rapid testing capability being rolled out. So these are tests that give a result in 15 minutes. They would be used predominantly to test people who may not be displaying obvious symptoms. There's a big interest in using those in health and care settings, and also I believe the national scheme to allow GP practices to order these tests has gone live today. So this will be continuing at pace over the next few weeks. And the final point is an interesting one, which is there's been a national announcement that the £8 per head funding given to councils under the second lockdown will partly be used to look at how we might localise contact tracing. So at the moment, we're in a good place across both councils because we've been working to support the development of welfare calls. So all of the notifications of positive cases that we receive are passed to customer services in both councils, and they put in a call just to make sure that they're checking in with the person, that they don't have any huge needs that would be a barrier to them self-isolating properly. Those calls are being very, very well received, but you could see quite quickly we might be asked to step that up and take on more responsibility for contacting people who test and trace have failed to contact at the first instance. And then if we went further than that, we might actually be looking at rapid contact tracing in response to localised outbreaks. So if we've got particular rises of cases in particular communities, we may be able to deploy those rapid tests and then perhaps ask people to notify their social networks quicker than test and trace could do. So some interesting things for us to consider about how we would develop that model under both councils. Just a couple of other points. We now run a full out of hours rota 24/7 with consultant cover all the time. And we've also developed our incident mailbox. So the public health protection inbox, which is very, very busy, is now supported by a fully staffed duty desk for that acute response work. So what was held very tightly by perhaps 4 or 5 of us in the early stages of the pandemic was never going to be resilient. We've done development work over the summer when the pressure was perhaps a little bit less to make sure that we've got a regular duty desk now with many, many more members of the team involved. And that seems to be working really well. So I think probably just finish on the outlook for the next month. We're obviously in lockdown. This gives us a chance to really work on our contain and enable proposals under that contain outbreak management funding that I mentioned. And I was just going to finish that our goal would be to be very clear that we're aiming to come out from lockdown under tier 1 restrictions and avoid going back into that discussion about the need for additional measures. So it's great news that cases are levelling off. It's even better news that they appear to be dipping slightly. We absolutely have to be taking full advantage of this pause now so that we can get cases back down. And if they're back down, that's the point at which our contain and enable strategy can then kick in. And hopefully we can reset that relationship with the public and do some much, much more detailed work on community engagement to try to really get the message across that unless everyone takes responsibility for this, it's just going to continue. So hope the board found that helpful. I'm more than happy to share the slides with David for circulation to members, but I thought it would be a helpful note to end on. Thank you.
If I may, and Sam, not only would it be helpful to have the slides for my own purposes to share with members, I think it would be beneficial if I was able to append them to the minutes, because in my view, it's not only informative in its own right to show what is being done, but it's important to see what is being done and the progress being made. And might I also suggest that comms might make use of those slides in showing what is happening.
Thanks, David. I agree.
Yeah, thank you both very much. I'd like to pretend that finishing on that note was always my goal, but that wouldn't be entirely clear. But David, I do hope that when those minutes are drawn together, you can put them in the order as that they appear on the agenda. So thank you very much for that. We have no urgent items that I've been notified of. So I wonder if I could just finish where we were in the middle, which is a brief reflection on how important it is that we still take the time to focus on the business as usual stuff and the emerging issues which this board has always had oversight of, but that we're conscious that we're doing it in completely unprecedented circumstances, and that work is going on at pace and at scale by a small and incredibly dedicated team of people who are understanding, I think, for you the accountable and very public realm in which we're all operating, but that having that accessible data is actually a great comfort to residents, that they at least understand where it's coming from, that people are on top of it, and that it is there and accessible for everybody to understand. So just in closing the meeting, again, to reiterate our thanks to the public health team, but to everybody else who supported this meeting and getting papers ready for today, and to members for their attendance. So thank you very much and goodbye.
Thank you. Bye.